Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education and is co-sponsored by the Academy of Breastfeeding Medicine.
Hey Karen, how are you?
I'm good, Ann. How are you doing?
Good. Well, this is super exciting. We have so many physicians on our podcast today, on our Zoom podcast, who are all, many, probably most, are breastfeeding medicine specialists and sacrificing their time with their children to talk about how their breastfeeding medicine practices are changing now with the COVID pandemic.
Yes, I'm so glad that you had this brilliant idea. And after we talked about it, we decided that we needed to spend really the first hour talking about outpatient practice and how people are adjusting to this current situation. And then we're going to spend a second hour focusing on inpatient and how we're dealing with those changes as well.
Right. So, so thank you for everyone who has joined. Karen and I are going to moderate some panelists, and we, as Karen said, the first hour will do the outpatient experiences. And what we're going to ask you to do is, first of all, we do know that some of you are from other countries. And so if you can just chat in any questions you have, but particularly if you're from another country and you have some things that you'd like to add, if you could just chat that in, and we're hoping that we can find time to have you voice your experiences. And for anyone who is hoping that they can talk during this podcast, if you wouldn't mind using a computer mic, because we are recording. So a mic that's through a telephone, if you're using your telephone to call in, the quality will not be very good. So that mic would be helpful. For everyone who's on, please know that this is recorded. So knowing that this also will be available for people to listen to for free. So just knowing that we are not planning on editing things that people say unless you feel very strongly about wanting something that you said edited out before we post it. There will be 2 SERPs available. One SERP will be an LSERP, and we figured that one SERP could actually be an ethics SERP, because we will be talking about some of the ethical issues that have come up in the changes in our practice. Okay, so I think we'll get started. So I don't think Kathy Leeper is on. Kathy Leeper was going to be our first panelist, but I don't think she's available. So I think we're going to start with Pooja Kakar. Pooja is a pediatrician and clinical instructor of pediatrics at Stanford University's Division of General Pediatrics, with her primary practice at Gardner-Packard Children's Health Center, which is a federally qualified health center. She integrates breastfeeding medicine with outpatient clinical care and the education of residents and medical students. So welcome, Pooja.
Thank you so much for having me. It's an honor to be contributing to this discussion today. So some of the things that I wanted to mention regarding our practice is, my 3 main goals when it came to being readily available to our breastfeeding mothers. One has been, continuing to be welcoming and accessible during this time of our state of emergency, but at the same time trying to minimize risks of transmission and keeping our family safe as well as our staff safe. In our area, we were hit relatively early with community transmission, and so at this point we are trying to minimize most physical visits in our practice. So right now we are seeing newborns and follow-up visits within the first month of life. And it's really important just to establish contact at that point and then continuing to follow up via phone and telehealth visits. So my second point has been increasingly using telehealth and phone to expand our access to care and be able to encourage mothers and infants to continue to exclusively breastfeed. And I feel like the third part of this that's really important is to continue to partner with our local resources and community organizations to make sure that we have wraparound support for families. And so with our clinic, we already had a close partnership with our WIC offices. And during this time, I have continued to remain in contact with our regional breastfeeding liaisons to be able to follow up with families that I'm seeing in clinic. The other aspect is to continually communicate with our local well baby nurseries. And so, you know, some of us in the Division of General Pediatrics are also doing weekends in our well baby nursery at Lucille Packard. And my colleagues there as well know how to reach me, whether it be by sending a secure Qualtrics form or secure email in order to follow up with mothers and infants, even those who are not necessarily going to be following up in our clinic. I think some of the main challenges that come with making all of these, you know, adaptations and daily evolving challenges have been ensuring optimal care with video visits. And I think that using, you know, various modalities, whether it be verbal explanations and visual demonstrations, if you are able to get a video and audio visit with the mother, as well as being able to, you know, email or in some other way send out additional information to follow up is going to be really important.
Great, thank you.
All right, next we're going to hear from Katrina Mitchell, who's a breast surgeon and breastfeeding medicine specialist in Santa Barbara, California.
Hi, I think my practice is probably a little bit different, just the nature of surgery. So really the main changes in my surgery practice have been related to seeing only cancer patients and booking out, for example, fibroadenomas that can be seen in 30 or 60 days. And I think this reflects what's going on nationwide. And I may be using more telemedicine for lactation as this kind of develops, but the nature of what I do in breastfeeding medicine, I think, is a bit different than what others do. And most often it requires an exam. And so far, none of my lactation patients and none of my cancer patients actually have wanted to cancel their in-person appointments. So I think it just really comes down to assessing the risk benefit in all of these individual clinical scenarios. And if it sounds like something that possibly doesn't need an exam, then we're set up for telemedicine here. But I had two patients, one with a mass on Friday that definitely did not want to cancel her appointment. And just a few weeks ago, I actually had a patient that was sent to me with a plug that was actually a breast cancer. So I think it's really just taking every case individually and triaging it.
Mm-hmm. Right. And what about I think one of the big concerns is patients who have respiratory symptoms. If you have a child with a cold, are you trying to keep people with respiratory infections out of your clinic?
Fortunately, we don't have a lot of that right now where we are in Santa Barbara. I know it's a different situation in the Bay Area. So we haven't actually had, at least me individually, I'm trying to think of, my surgical partner had someone show up to surgery actually with upper respiratory symptoms last week and wanted to stay overnight so she didn't have to be with her husband, who apparently had the same symptoms at home. So I think we are probably, you know, struggling to try to triage these people before they come in. But I guess individually, I haven't experienced this yet. I've had some kids with snotty noses, I guess, that have no other symptoms. Like, it's not a other concerning situation. Like, I'm just trying to think of people individually right now.
Yeah, that's okay. Yeah, I'm just wondering about office policy, really. Okay, well, let's
Yeah,
move
I mean,
on.
we have, in terms of office policy, we have at our cancer center, people are being stopped. I assume this is happening everywhere. People are being stopped at the door and asking if they have like a cough and a fever, and they're getting their temperature taken. I don't know if that's what you mean.
Right, exactly. Yeah, yeah. Okay, thanks. So next we have Rebecca Hicks, who's a pediatrician and a IBCLC practicing outpatient pediatrics and lactation at an FQHC in Bend, Oregon. She did her residency at Stanford with the amazing Dr. Jane Morton, and then practiced as a newborn hospitalist at a large Stanford affiliate hospital. She moved to Oregon 3 years ago and started a lactation program at her current clinic. So welcome, Rebecca.
Thank you so much for having me. I really appreciate being here today and being able to share these experiences. So currently, I am the only breastfeeding medicine physician practicing in my town. And as other lactation practices and as the WIC offices here in town have all closed, it's been very important for me to be able to continue seeing dyads in person. So I am doing some phone visits and have not yet done any video chat visits, but I'm trying to get that up and running. But in the meantime, I have been needing to continue to see these dyads in person. So I tend to have the more challenging mother-baby dyads in our town, and really, as you all know, need to be hands-on to help with the latch and to assess the oral anatomy for these dyads. So I've been able to continue seeing these mothers and babies. And so I work for a general pediatrics FQHC, but luckily we have 6 locations. So what we've done is turned one location into basically my location, where I see only mothers and infants 12 months and younger, focusing heavily on trying to see newborns and the first month of life. So steps that we have taken to reduce transmission of any infectious disease during this time are that we're screening on the phone the morning of the appointment. So we've pushed my appointments back a little bit, so I start a little bit later so we have time to call every patient that morning so we can screen for symptoms over the phone. So we do that, and if a mother or the baby has any symptoms, then we do not allow them to come into clinic, and we reschedule them and then turn that into just a phone-only visit. So we screen them on the phone that morning, then we have our door locked and we screen them again on arrival. So the only people we want coming into the clinic are our mother-baby dyads. So they come into the clinic, we take the mother's temperature and the baby's temperature and screen them again for any respiratory symptoms. And again, if they show up with any respiratory symptoms that they hadn't reported over the phone, then they're not allowed to come in. So then we have only 2 dyads in the entire clinic physically at one time, one in the exam room with me and one can be checking in the waiting room, but we've limited it to that. So we've spread our appointments out a little bit more. And then we are wiping things down tremendously with Sani wipes, wiping down the infant scale, wiping down the chairs, wiping down every surface that could have been touched. I can't remember if I mentioned we're also not allowing fathers to come in, which has been hard, but we're having, or partners, I should say, we're having patients express some discontent about that because, you know, these brand new moms with newborns, they want help, they want support, they want other people to have this information, and, you know, sometimes they just want somebody to carry the car seat in for them, but we're being strict about only allowing the breastfeeding mother and the baby into the clinic. So far, it's working well. I've been really happy to be able to continue this work, but I can't say that it's not without concern. I do continue to have concern for asymptomatic spread, and I'm doing what I feel like I can to mitigate that, but I just can't say for certain that this is something we'll be able to continue long term if this pandemic continues as long as some of us think it might.
And why do you say that?
Well, if more and more true studies or research come out suggesting that asymptomatic spread is one of the main modes of transmission, then I'm not sure that ethically I can continue to justify bringing patients in for in-person visits. But I mean, it's a tough scenario. I really don't have the answer to it. It's just something on my mind because this work is so meaningful and so valuable to give these tiny little humans who didn't ask to be born into a pandemic. We want to give them the very best chance that we can. But I'm just not sure. I don't know what the answer is. If asymptomatic transmission is one of the main modes that this pandemic is being spread, I'm not sure that I should continue.
Mm-hmm. What about, do you think that there's any way that you can continue if you are even more strict about, and I've heard some people having the next family and stay in the car, and then one family's in the office, everything gets wiped down, the next family comes in after that, so there's absolutely no possibility for them to come into contact with each other.
I think that's a reasonable next step. I also worry about myself, asymptomatic spread. What if I have it and I have no symptoms? And should I be wearing a surgical mask all the time? Should I be wearing an N95 mask all the time? I'm inches away from these mothers and babies' faces when I'm working to get a good latch. And I don't have a good answer to that question.
Right. Yeah. This is really one of the most difficult questions. I guess one other thing I wanted to mention is the issue about not having the partner in. And I wonder if people call their partners to join in by phone into the consultation.
It hasn't happened yet, but I think it's something I could definitely suggest or bring up. And that seems like that would be easy.
Yeah, I actually do that a fair amount in my practice anyway. Even for pediatric, like well child, sometimes the parents working and they just want to be there for the well child exam. So they'll just, FaceTime in or just call in to the exam.
Hey, this is Karen. I had the same idea when you were talking about partners. There are certainly times when we phone partners. We also sometimes make videos of parts of the latch process for both partners and for moms to be able to review once they go home. Oh, I'm going to interrupt myself and say anybody can write a question in the chat box if they want to. I also just added into the chat box the name of a new tool that I just learned about this week called doxy.me, which is a HIPAA compliant, like it's supposed to be a telemedicine platform, but you could also just use that to reach out from the patient or yourself to the partner who's not there. And it's really neat because you don't need an app. It's just free through the website and it's really easy to use. So it's something some people might want to check out to start that. And then the other thought I had is in both, myself thinking and Katrina and you, a lot of these visits do need to be hands-on, but sometimes we don't know until the visit starts really whether or not it's going to be. And I'm thinking as people get more hesitant to come to clinic, because I had some cancellations this week, it may be a way for us to at least start to help them and then figure out like which patients really need to come and which ones don't.
Mm-hmm. Right. Yeah. And I think if you have someone if you have office staff who can do that kind of triage, that really helps quite a bit. I know, Karen, you've mentioned that you don't have that person.
I'll be the one doing it, but I'm still grateful to have the opportunity to sort of check in with people because sometimes they really, especially for a second visit, if things are going well, we can often work more on the phone if we don't require a wait. And not everybody I see, for instance, people I'm treating for pain, I might not need a wait.
Right.
But sometimes you really do need to have them come back.
Right.
Can I say something about weighing and infant scales? I've seen on social media quite a bit of talk about suggesting that parents buy their own infant scale. And obviously that's limited to people who have the resources to do that. But I also just have concerns about the inaccuracy of those scales. So as I started this program a few years ago, we tried not to buy a $2,000 scale. And so I went through 3 other cheaper scales and they were wildly inaccurate. They really, really cannot be relied on for checking transfer in one feeding may be reliable for checking weights over 2 or 3 days, making sure you're moving in the right direction. But I have concerns about people suggesting that families buy infant scales to check transfer, when I think you really have to have an expensive scale to get an accurate weight.
Yeah, I find that, yes, I agree. This is Anne about the pre and post feed weights, but in this, if we're trying to keep people out of the office, I agree with you that we could probably just go with like how much are you supplementing and what's the baby's weight, and that sounds good, and not have to worry about the pre and post feed weight as a general rule, because our that micromanagement may have to be tossed aside at this point, and then just making sure the infant's gaining appropriately. There is a question about, does anyone have recommendations for the least expensive reliable scale? And if any of you who are on the panel for this hour want to chime in, I think, Rebecca, you answered that that you've tried several different ones. I know I've had the Hatch scale is kind of expensive. Some of my patients have purchased that, but then I've had some people you buy a $35 kitchen scale and have really liked it and have found it to be reliable when they report weights, and then when we check in as well, but I'm not sure which brand that is. So if anyone has any ideas, you can chat in.
This is Katrina. And you had suggested a couple years ago a Seika scale that I had in my last practice, and I was happy with that. But then my new practice gave me a scale that is one of the clinical scales like the pediatricians have, and I have to say I like that better. And then also I realized as Rebecca was talking and she was detailing the procedures they have for patients and the wiping down with wipes, we have that all in place in our cancer center. And I guess that I didn't realize that's what our questions were about. I was thinking more about, I have, I guess, the luxury of the staffer doing that. And so I'm not the individual person screening patients, or we have restrictions for family members. But I'm not the person telling people that, they can't bring extra family members in, but we have basically a policy throughout all of our clinics in our physician group.
Mm-hmm.
Standard.
Okay, well, I think I'm going to bring on our last panelist for this hour, Shauna Lamond. And Shauna is a family physician and breastfeeding medicine specialist in Calgary, Alberta, in Canada. She's the director of 2 infant feeding clinics in Calgary, one in Riley Park, one called Riley Park Lactation, and the other called Well Fed Clinic. And she has a special interest in musculoskeletal issues that affect suck, swallow, and latch. And she's also a clinical lecturer at the University of Calgary Cummings School of Medicine. Hi, Shauna.
Can you guys hear me now?
There you go. Yep, we can hear you.
Okay. Well, thanks for having me. We have a bit of a different system in Canada because we have a fairly, everyone's connected because we have a public health care system. In fact, Alberta has the highest testing rate for COVID-19 in North America right now. So we are very heavily testing patients for COVID-19. We have a process right now where we phone screen all our patients the day before clinics. And if they screen negative on the phone, then like Rebecca was saying, they can come into clinic. We screen again at the door. And so we have far fewer people coming in the office. We've made a commitment to no people in the waiting room. So we will call people in from their cars when we're ready for them. So we do have a number of rooms actually. And so we only, we book lightly, and then the rest of them are phone and video conferences throughout our day. Right now what we're doing is trying to—
Whoops, I think you're cutting out.
The babies. Oh, sorry.
Oh, you were just cutting out.
Can you hear me?
That's better.
Okay. Yeah, is that better? So we have our public health nurses who normally do all the TCB and weights right after hospital discharge have been diverted to testing and call centers. So what we've had to figure out as a lactation group, and luckily we have a robust group of us, is how we pick up the postpartum discharges. So we've been in conversation with the low-risk maternity groups, obstetrics, and public health over the past week to make sure these babies don't fall through the cracks. So we are developing a protocol where all screening negative patients will be sent to one of the breastfeeding clinics, and the positive patients are going to be remaining at home in isolation, and we will do care delivered in their house in full PPE. So this is how we've managed to try and cope with these changes. Everyone in Canada here pretty much is on self-isolation now. There's not a lot of movement. People are not doing things. So there's very little movement to most family medicine clinics right now. One of the big problems that I was talking about with our director at the milk bank is they have very few donors coming forward right now, because in order to get the blood work done, they have to go to one of our public labs, and they do not want to go to them right now. So we're in the process of figuring out a safe way that they feel like they can get that screening done so they can still donate milk. And we're trying to figure out some of the volunteer groups that can go around and pick up milk from Women's House so they don't have to leave. So we're in the process of sort of partnering with everyone from the pregnancy care providers to the hospital to public health to the milk bank to try and create a web where we keep these babies healthy with low risk, higher risk individuals and COVID positive. So it is quite a process here.
Yeah, that's amazing. So it sounds like you have much more testing. And would you say that anyone can get a test for COVID who wants to?
So we have a screening tool online. So you go to Alberta Health and you go do the screening tool online. And if it is that it says that you should get a swab, then you call 811, which is our number. And that's what public health is staffing right now. And then you are directed to a drive-through or a testing center. So we have our testing centers are screening a lot. And our numbers aren't jumping really quickly now because we have really gotten social distancing and home isolation happening very quickly in Alberta. And our numbers jumped up yesterday, but not nearly as quickly as they did the previous days. I'm hoping that this is starting to flatten here. But yes, we are testing. I mean, I think the numbers I looked at today, we are the #1 testing jurisdiction in North America.
So someone asked, who is doing the home visit?
So the home visits will actually be public health and one of us lactation physicians likely, who will go in full PPE gear. And the only reason I would go into the house is if a sternotomy needed to be done to protect breastfeeding. So actually, if it is that it is a COVID positive family, public health actually still will go in full gear for one of the public health nurses, and they will do the TCB screening, the weight, and draw the blood work on the baby. If we will do the rest of it, we'll do the rest of the visit by video conferencing. And I have 15 scales that will go out to those homes with public health so we can follow that infant's weight for 2 to 5 days and make sure that it's trending up. And so the only reason we would go in is if the public health nurse is thinking that it really is a tongue tie that's impacting a negative breastfeeding relationship, and then we would go do that assessment. So we're hoping that isn't too many families. But we have gear, we have our PPE gear at our clinic, and we will be ready to go if we need to.
Great, okay. Someone asked about having mothers wear masks when they come in for the visits. Anyone have any comments about that?
Yeah, hi, this is Pooja. I responded in the chat, but just to elaborate, so given current PPE shortages, we aren't seeing shortages in our clinic yet, but are starting to within Stanford. We are not having moms wear masks. However, there are some physicians based on personal discretion that are choosing to wear a simple surgical face mask in order to avoid us spreading asymptomatic transmission to our patients.
Mm-hmm.
And I think other steps that that we have also taken have been to move towards skeleton crews within our clinic. So our setup has been before COVID that we have a separation with distinct sides of clinic for continuity well visits and for our urgent care sick visits with separate entrances for each. So in some ways we were already prepared for this, but I think that separation also helps to divide the other staff and clinic, nurses, MAs that are attending to patients, and overall minimizing the visits that are coming in. So for our practice, all visits under 2 years old are only coming in for a vaccine visit. But if there are questions, then we are answering them via phone or a telehealth visit. And for only our newborns and infants under a month old are the ones that are getting face-to-face visits at this point. And that's something that is challenging to move towards, especially in our community. But we're kind of seeing how things go. And then to comment on Karen's post about DoxyMe, that's been the main service that we've been playing around with our telehealth visits, and have been moderately successful with that so far.
Great. And what about other people? Are other people getting ramped up for like a standard telehealth process or program? I would say that from my own experience at the University of Wisconsin, we were about to launch in the next year or so our telehealth, full telehealth program. And we are now launching it this week in order to actually provide telehealth in a more comprehensive way than just the phone calls that we've been making in the last week. I think that I'll just join in as a panelist and tell you what's happening at the University of Wisconsin. According to our administration, we have the largest outpatient primary care system in an academic setting in the country. And so we have about 30 primary care clinics, which includes peds OB and family medicine. And then in family medicine, we are trying to distill ourselves down to 10 sites in order to close some of our clinics. And so our breastfeeding medicine practice is 3 physicians between 3 different clinics. And so we have one main phone number for our breastfeeding clinic, and then our nurses triage those patients to one of the 3 clinics, and we're spread around the county. And so the fear that I've had is that because some of us are going to be in telemedicine and some of us are going to be in the clinics with limited face-to-face, and the 3 of us are in different parts of the county, now being split up into separate clinics, we're having to refigure how our patients are going to reach us, how our referrals are going to come to us. And so it's quite stressful right now. I also feel that there's more urgency in helping these families. And so whereas undoubtedly patients would wait a couple weeks to see us, they would first see a lactation consultant in the community and then wait to see us for more advanced breastfeeding medicine care just because we're booked. Now I feel not only are we trying to get them in faster, but also we're seeing things that the lactation consultants could probably be seeing because they're not as available. So it's kind of, I don't know for any of you who are on the panel, if you feel like it's changing the breastfeeding medicine patients that you're seeing, if you're seeing more basic stuff, because the lactation consultants in the community are not able to do the primary care lactation work.
Hey, Anne, this is Karen. I had mentioned to you on the phone that, my practice is normally people who have seen multiple providers before they make it to me. And often I have a lot of older babies, and because they've shut down our hospital support group and they have stopped a couple of other outpatient lactation providers. I mean, the hospital inpatient lactation consultants normally do a few outpatient visits. They've decided they're not going to do that right now. I've decided to limit my new patients to babies who are less than 2 months, because babies who are older than that, the moms are feeding them something. So hopefully they can at least continue with what they're doing. Whereas the younger ones, I feel like it's more critical to try to intervene at this point.
Mm-hmm.
But it's too soon to say how that is going to play out with the numbers of visits that we're going to see. I look at all the different posts everybody's doing here in the chat, and there's people who have great access to testing and people with none, like us, and people who have great PPE and people who have none, people who might be sending scales home. We have 10,000 deliveries a year. That is not going to work for us.
Right. All right. Anyone else have anything to add regarding outpatient management? How many of you have, so I think it was Rebecca who said that you have, oh no, it was Shauna who has the connection with public health. And I feel like the public health system, from what I understand in talking to various physicians in Canada, that public health plays a very important role in newborn care in some of the provinces. And I'm wondering if this is something that others are, if this is something that people in the United States have been experiencing, what their connection has been to public health in their communities.
I can speak for public health here in Central Oregon. Well, I can't speak for them, but I can tell you my interactions with them have been that they are extremely overwhelmed, that they are so overwhelmed with the lack of testing supplies and the lack of PPE among our community. And we are unfortunately one of those communities, and I think my whole state really is affected by very critically limited ability to test and critical shortages of PPE. So they're so overwhelmed with that they haven't been able to continue their standard efforts in any other arena in a meaningful way.
Uh-huh. So what have you heard about WIC? So Dr. Susan Crow mentioned that WIC has closed in her area, which has had a huge impact. Maybe we'll have Susan talk about that. Let me see if I can unmute you, Susan.
I think I just unmuted myself.
There you go.
Me?
Yeah.
No, it's just, I work in the OB clinic and we're in different silos at Stanford, and the OB clinic patients that we've had multiple people coming through who have not gotten the breastfeeding support that they usually would get at WIC. And so I see that becoming a worse and worse problem for them.
Yeah, I think, I had talked to one state breastfeeding WIC coordinator who said that they were pretty much trying to, still bring in people. I'm doing some drive-through food packages, things like that, like trying to come up with creative ways to keep the social distancing. But they also said they're having trouble getting formula. And she cited a client who was Amish, who was breastfeeding, but her baby at 6 months was 13 pounds. And they felt that the baby needed alimentum, and they didn't have any, and they couldn't get it. And so they were quite worried about that. And so I had suggested that she contact the milk bank in that state to see if they could come up with some sort of arrangement or communication about how to help some of these desperate families.
Mm-hmm. Yeah. I haven't heard anything about that specifically.
Yeah.
This is Katrina. I'm actually interested in the formula question because when I was grocery shopping yesterday, I actually went by the formula aisle to just see what was going on because of course we literally have no toilet paper anywhere and like all of the stuff that's going on elsewhere. And I was interested to see that the formula aisle was completely stocked. Has anyone noticed that in their communities?
Can you say that again, Katrina? I'm sorry, I was watching, but I was reading what Yvette had said about Puerto Rico. Can you say that you can
comment on it, Katrina, and recap as well? So she was saying she noticed there was no toilet paper, but the formula aisle was totally stocked.
Oh, interesting.
And what I would say is, from my experience looking at different grocery stores here, it probably had more to do with the fact that they had just restocked the formula than that it had gotten bought out, because you'll notice like every day a different thing is missing. And it's because there's no problem with the supply chain. There's lots that's going to keep going into the stores, but as soon as they stock it, people are buying it out. At least here, they've been asking us in the hospital to send extra formula home. Some families have been asking us because there's none in the stores.
Yeah,
so I think it was just a timing thing.
Okay, because I had assumed that was going to be the first thing that people hoarded, which is why I was so interested to see it stocked. And then I thought maybe it was because the formula supply chain is so strong that it's actually way stronger than, for example, toilet paper, which is kind of scary.
Mm-hmm.
Yeah, this is Pooja. We've been getting similar questions from our Well Baby nursery at Packard as well. And we've been telling families that they can also contact the formula companies directly. I don't have personal experience with this, but based on our, the threads on social media with physician breastfeeding groups, it seems to be a viable option.
Mm-hmm. I'm interested in hearing from Yvette with how things are going in Puerto Rico. Yvette, can you talk? Can we hear you?
I'm mute. Wait.
Oh, you're on now.
Let's see. Can you hear me now?
Yes.
Can you hear me?
Yes.
Oh, yes. Well, in Puerto Rico, what we're doing a lot of Zoom conferences for pediatricians. We created like a chat for disasters, and we're trying like everywhere. And we have here a limited, we've been quarantined since last Sunday, so everybody's staying at home. So we're getting I've done a lot of teleconferencing and screening people. I've only gone to my office twice this past week, and I wasn't really how I was going to do then the Well Baby visits next week. And the governor just created a task force and included the director of the pediatric hospital, because we're really concerned when the cases start jumping up. We've had 1 death and 23 confirmed cases, but very limited testing. Apparently it's going to start tomorrow. When I heard our colleague from Alberta, so easy was to get tested, we have no testing, and we had the problems here about the cruise ships staying here, but I think we're gonna do a good way with the quarantine. It's been working quite well, so that's all I have to say for now.
Yeah. So are you doing, in terms of like pediatric care in the clinics, what people have been talking about, is that similar to what's happening in Puerto Rico too, where you're trying to limit the number of people that you're seeing in the office and focusing on newborns and other urgent issues?
Exactly. Yeah, most only big clinics maybe are still working. Most we're doing all by telephone. And like I told you, last week I worked 2 days out of 7 and tried to manage everything via telephone and video conference. So we went 2 days to immunize some children, and we're doing it day by day because we have so many other issues that we have to solve. So basically, I'm learning with all of your experience at the same time, but we're screening. My office building, for example, is closed. We have digital entrance, and persons call us from their car. We go down, somebody from the office goes down, escorts 2 people up, and then they go down. So we're seeing patients on a 1-to-1 basis, limiting people in the elevators and trying to continue with the social distancing.
Yeah. Okay. So I want to thank you, Yvette. I want to talk about telemedicine. Some people have been asking about telemedicine and in ways that they're using that. I guess I would start by saying that we've been very fortunate at the University of Wisconsin that we have had our plan in place, and we have been using it in urgent care for some time, and it's just has been an issue of rolling it out to the primary care physicians who have not been using it yet. So we're hoping to do that next week. But up until then, we, because we have Epic, and we've converted visits to telehealth, and they've just been phone calls. And then what we've been trying to do is document the work that we're doing by using the E&M code is actually just a 02012, which is like the phone message code. and then you can put in your minutes so that we can document what we're doing. And then just documenting just our conversation via phone. Our patients can send in photos, which is nice. I think that's probably an upgrade that everyone got for Epic. And that's been helpful for things like rashes. I had one mother who I did a telemedicine visit for, who I had not seen before. And I can't remember exactly what the issue was, but I thought like one thing that needed to be ruled out was a tongue tie. And the baby was going to the baby's family doctor. And so the family doctor took a picture under the tongue and sent it to me. And that was really helpful. So kind of working together with different people, that's where having in EMRs, particularly, I don't know of any other EMRs, I just know of Epic, but that's been very helpful. So I'm wondering if anyone else has any other comments about what they're doing for telehealth. Anyone on the phone? I guess you would
I can comment a little bit. We, if that's okay, we started offering telehealth in Columbus, Ohio. We use eClinicalWorks.
This is Rebecca, right, Dr. Hicks?
This is Divya Parikh.
Oh, hi, Divya. Hi.
Hi. Yeah, so we are using Helo to coordinate with all of our patients, and it works pretty well. They get web enabled, and they kind of we schedule them, and then they log into the visit through their app. And I've done one lactation visit in the last week via telehealth. I mean, I think it's been helpful in that, you know, we can reach them, we can see them in their home environment and do everything. The way we've been billing for it, we have a different way of billing for it. We have like 99201 to 99213, you know, that E&M code for it with a GH modifier. And that's sort of how our group has been doing it. So maybe that might be something worth looking into so you can get reimbursed a little better.
Does that dovetail into Epic, or is that a totally separate? Like, do you use Epic where you are?
We don't use Epic. We use eClinicalWorks.
Yeah. And that we are using that with our Epic in DC area.
Okay.
Mm-hmm.
Yeah. I would be curious to know if anybody else who has been doing it, if they have like specific scenarios that are better suited to televisits versus others that really should just be try to come into the office. That's sort of what I've been trying to tease out a little bit better.
Yeah.
Yeah, I can comment on that. This is Pooja again. With our, you know, I think the importance of the initial consultation still remains. And so it depends on like degree of weight loss and, you know, how comfortable a mom feels with breastfeeding, if she's had prior breastfeeding experience. Based on that, and then other factors, like if we need to follow up on a bilirubin as well, then we'll have a follow-up visit. But if they seem to be doing relatively well, and we think that, you know, it's sort of based on judgment rather than a precise algorithm at this point. But yeah, based on that, we sort of figure out if doing the telehealth visit will be adequate. And then, you know, the other part of it is that you can also use it as a sort of triage, whether it's, you know, a physician doing this or a nurse, to determine, you know, if they really warrant an in-person visit. You can use the video or just a phone visit to screen for needing to come in or not.
Right. I think it depends on the population you've seen, and certainly this whole decision-making process of who's already on the schedule now, who can we convert to a telehealth visit, is going to be so individual, like those breastfeeding consults. I would say about 10% of what I do in my breastfeeding medicine clinic is our prenatal consultations, as well as induced lactation and for adoption or surrogacy. And those I can certainly do over the phone, except when it comes to like checking their pumps. But even that, we can, once we have the telehealth up and I can actually see what's going on, I can actually, other than not being able to put a gauge on their pump, you know, I think that will help quite a bit. So I think a number of the patients that I see, I'll be able to do via telehealth. But whenever there's a weight check, it's trying to figure out like how to get that weight, and then how to watch a suck, and which I guess you could do via telehealth. and then being able to look under the tongue. And I think it's very difficult. I even find that my residents who work with me, teaching them how to isolate the tongue and how to lift up the tongue to look at a frenulum is tricky, and it's particularly going to be hard for parents to be able to demonstrate that via telehealth.
Hey, Anne, this is Karen again. I would say when I think about trying to triage patients and sort of deal with the most urgent problems, because if this goes on for a long time, which I think we're starting to think more and more that it will, if we're continuing to restrict the, number of patients coming to the healthcare system, the ones that really can't go to their primary doctor, and this will probably come up in the second hour as well, I want to know, are those babies getting enough nutrition? Do we need to increase supplementation with pumped milk or formula? I need to know whether or not the mom is really effectively removing her milk. And so, I'm sure you guys have, a lot of you who listen to our podcast have heard me say this before, but I have when breastfeeding sucks, which is all the time for people who come to see me, I have a 3-step plan. 1, feed the baby something. 2, remove milk. And 3, maximize rest. And so for number 1, I may not be able to weigh that baby, but being able to see the baby's mouth and talk about the output, it will, depending if it's a really small baby, let me know whether or not we need to do some sort of urgent increase in the amount the baby's getting. And then for a lot of people, they might not be gaining optimally. They may be getting 15 grams a day rather than 30, but that baby isn't going to be in giant trouble if they don't come in 2 days, if they're gaining, albeit slowly. And so I think about this as sort of trying to identify which ones, okay, I can tell that baby is thriving. Okay, I can tell that baby's not. Okay, this person, I don't know, they need to come. And then really seeing people pump. I see so many people in my practice who are just not effectively removing milk. They've been given the wrong size flanges or other things like that. So I think those are the places where I'll focus trying to initiate with telehealth. I'm curious what people think about that and how they might change it.
Right, great comments. I wanted to ask Adrienne Hoyt to unmute and see if she wanted to mention something about telehealth and at UC Davis.
Hi, everybody. I am a general pediatric academic fellow at UC Davis, and Laura Kerr and I are studying telehealth in late preterm infants. She's not on the call right now, but I discussed talking about our research. I don't have any results to discuss, but I can tell you about my personal experience with conducting the lactation visits via telehealth. We started doing visits for late preterm infants back in September, and I do the majority of the clinical visits using Zoom video and then documenting our notes in Epic. I cannot comment about billing because we have not been billing our patients since they are research visits. I would say that the majority of my impression is that we've had, that the mothers have really appreciated the telehealth visits. And you can really get a pretty good, not great, but pretty good assessment of latch. And just by visualizing the baby's mouth on the breast, you can get a pretty decent breast examination. If mom goes into the bathroom with her phone and turns on all the lights, it's not perfect, but I would say that in the time of COVID pandemic, it's much better than nothing. And then I've certainly helped out moms with fitting their breast pump appropriately and just plugging it in. And as many of you know, so much of what we do is counseling, and I think that it's been really invaluable. I can't comment on our results because we haven't examined our results yet, but that's been my impression.
Great, thank you. Yeah, you mentioned that you do Zoom, but Zoom, I guess, do you have concerns about the HIPAA compliant issue with using?
So we have a HIPAA compliant access to Zoom at UC Davis, but I've heard that in the last week, that the Department of Health and Human Services has waived a lot of the platform necessities for having HIPAA compliance. Obviously, every practice has to discuss what they are comfortable with doing. And then recently at UC Davis, we now have televisits embedded within Epic. So those are HIPAA compliant.
Great, thank you. Yeah, I did
No
hear
problem.
that was also spread through the UW that the I think it's Office of Civil Rights from the U.S. government has waived the HIPAA compliant rule, but they're still encouraging us to use the HIPAA compliant, to use HIPAA.
Oh, absolutely, absolutely.
Yeah. Mm-hmm. Okay. Anything else? I think we're going to, in about just a few minutes, we'll switch over to the in-hospital issue. Anyone from any other country who would want to talk about what they're doing in their country? And then also, there's Laura. Laura, is Laura in Quebec? So Laura, do you want to speak? I think she might be coming on here.
Oh, sorry, I just came in. I don't know.
Yeah, we're just finishing up our first hour, our section on how our breastfeeding medicine practices are changing in the outpatient sector. So knowing that you're from a different you're in Quebec, is that correct?
Yes, yes.
You want to mention how things are going there?
So here, a week ago, we went into telemedicine. So the pediatric clinics, baby clinics, breastfeeding clinic, we're all doing it either by phone or by by Zoom. And now in their electronic chart, they have integrated a telemedicine function, so we can use that. And they're discouraging face-to-face interviews. Can you repeat me the question again? Because
no, and any other way that you feel that your routine in caring for breastfeeding medicine.
Yeah. So essentially, I went with my colleague Christiane Charette, who's, I don't know if she's on the call, and tried to decide, if there were what issues patient would have to come in for breastfeeding clinic. But so far, all my patients, the patients don't want to come in to the clinic either. So it's a really, I haven't encountered a situation yet that I cannot do on telemedicine. I haven't had a frenotomy, for example, yet. But when the occasion comes, I guess we'll have to be in person. And the other idea that we were having, I just bought a baby scale for borrowing. So the patients don't have to, one of the main indicators for breastfeeding success is weight gain, weight change. So my clinic closed. We are a satellite clinic of a big other primary care clinic. So my smaller clinic closed, and there's two other baby scales that I can borrow. So we would have 3 baby scales for the patients to take home to follow up the weight. And yeah, the only thing we're keeping here for now is vaccinations and any other reason that requires in-person visit. But the vaccinations, we decided, public health has decided to keep 2 months, 4 months, and 12 months. Anything after 12 months, it can be delayed. We don't have a 6-month vaccination in our calendar anymore. So it's a big adaptation, but it's going very well. We expect to see 90% of our patients from home.
Excellent. And so Joss is asking what kind of scale you're using, what kind of scales you're using.
Well, so I have to say, I discussed with the lactation consultant, and I bought one that wasn't too expensive. It has a plus minus 5 gram error. Mm-hmm. It has a funny Finnish name. I can give you the name in a minute. There's a camera here. Okay. And no one has a camera, so I'm gonna pick it up.
Yeah, we're actually not using cameras.
So I decided it's not expensive. It's $60 Canadian plus tax. So I figured it was worth. And we're also wanted to recommend that clinics in general try to equip themselves with extra scales. So Christian is on the call. So I don't know, Christian, if you have talked already, I'm sorry.
Good afternoon. No, I did not talk yet. We're just trying to, we're just sorting this out in the last week or so. Personally, I did one breastfeeding assessment with a video camera with Zoom, and I was very satisfied. The mother too. The nurse was present was in the same room with the mother. It went really well. It was for pain with breastfeeding for a baby that was almost 3 months old, and we did get a good idea of the situation. I was thinking today, I heard that some ENT do the, or even dentists that do the frenotomies in the baby in the car seat, and I was just trying to figure out if we could consider this a drive-through.
Okay. Yeah, it seems like other people have said that as well. And I just want to close with one thought, and that is that I've noticed that other specialists have been paying attention to the needs of breastfeeding dyads, at least in our community. Our ENTs have been, who are in other parts of the county, have been willing to see babies with tongue ties like that day and just clip them because their offices also are not very busy. And, you know, if you think about ENT patients, that's where all the COVID is sitting, is right in that nose. And so they, I don't think, really want to do much in the way of any ENT surgery unless it's an emergency like trachs or, you know, like trauma is my understanding. And so they have a lot of availability right now if they're skilled at doing frenotomies. I know that Dr. Kathy Leeper was going to be one of our first speakers, and she's now on. I know she said that she was busy.
I am.
Yeah, so can you just, so we're going to move into the hospital portion of our conversation, but I want you, because you have kind of a unique practice, I thought that we could just get you to talk for like 2 minutes about what you're doing at in your practice. And I'll just do a brief introduction that you are, Dr. Kathy Leeper is a pediatrician and breastfeeding medicine specialist who co-founded a nonprofit breastfeeding medicine center called Milkworks in Lincoln, Nebraska, with a second clinic in Omaha.
I am so sorry. I was on another Zoom with my lactation consultants, and it took an hour longer than I anticipated because we are starting telehealth tomorrow, and wanted to talk through all of the logistics of that. So that is one thing that we're doing that is brand new, is in talking with everyone. We are going to try and triage nearly everyone via telehealth first for our lactation visits. And we are not allowing anyone to come in the front door without an appointment starting tomorrow. So that is the biggest difference.
Hey, Kathy, can I ask you a question? Just because
Sure.
I saw a post that you put up, and we just talked a little before you got on about how insurance was going to pay for telehealth, and some legislation has happened to waive some of the rules about HIPAA compliant platforms. But you had mentioned trying to ensure that malpractice was going to cover those lactation consultants for their telehealth work. And I'm wondering if you've gotten any more clarity on that.
We filled out a form on Friday answering questions, and I truthfully have not heard back that has been approved, but the person who sent us the form said that they didn't think it was going to be a problem, and I guess I feel like in this current moment, we're going to go ahead anyway. Based on my understanding of our malpractice as physicians, that we can only see people in states, or see virtually. We can only do telehealth with women who are in the state in which we are licensed. So we will start with only Nebraska, and until we get clarity that they would be okay to talk to someone across the border.
Okay.
Thanks.
Well, thank you so much. So I think we're going to move into the hospital portion, which I think we have so much to talk about in that realm. So those of you who were on the initial panel, thank you so much. And I'm going to ask you to mute. And then for those who are going to be speaking on the second half, we'll ask you to unmute. And we'll start with Dr. Chandria Johnson, who's an OBGYN with an interest in breastfeeding medicine, practicing at Mercy Hospital in Springfield, Missouri. Her primary job is a full-time OB hospitalist. She also works part-time in the office practicing breastfeeding medicine and collaborating with the hospital-based midwifery program. So welcome, Chandria.
Hi, thank you for inviting me to contribute to this webinar today. My area has only recently been directly affected by COVID, with about 11 confirmed cases, including several critically ill patients. My facility is trying to plan for the expected rapid increase of COVID patients over the next few weeks, and we are unfortunately already seeing shortages of PPE. We stopped all elective procedures a week ago, closed our outpatient surgery centers, and started limiting screening visitors last week. Yesterday, we severely restricted to include no visitors for most patients, 1 support person for laboring patients with no switch-offs, 2 parents or guardians max for each NICU baby. All visitors and employees are screened for fever and symptoms upon entry to the hospital. We reviewed last week and adopted the University of Washington's protocols for management of pregnant, laboring, and birthing mothers who have influenza-like illness, confirmed COVID-19, or are persons under investigation. UW has provided triage guidelines for outpatient and inpatient OB patients to direct if and where patients are evaluated if they have concerns for influenza-like illnesses. In our facility, we now have a dedicated OB operating room and 2 dedicated labor rooms for influenza-like illness and COVID-19 patients. Our hospital as a whole has a designated ICU and a medical floor for COVID patients. The NICU has a majority of private rooms at baseline and can maintain isolation for preterm or sick babies as needed. Due to the significant decrease in surgical volume, our women's surgical unit, which is already equipped and the staff is cross-trained for mother-baby care, will, at least in part, become a COVID isolation unit for mother-baby care as needed. This will allow for mothers and babies to be isolated either together or separately as the clinical situation and the mother's preferences demand. This will keep term well PUI babies out of the NICU. I have advocated to follow the University of Washington protocol, which is in line with the ABM recommendations to keep term well babies with the mothers who are mildly ill or PUI, using masks for breastfeeding and keeping babies 6 feet away from the mother when not feeding. The NICU docs are currently reviewing this plan, and we will have an official policy for our hospital likely tomorrow morning. Some hospitals are recommending automatic separation of mothers and babies if COVID-19 is suspected or confirmed. There are logistical concerns with this, as every isolated well baby will need one-to-one dedicated caregiver, which may potentially need to be a hospital staff member if the mother does not have a support person available. For mothers who are separated or otherwise need pumping, we do have breast pumps available in every postpartum room that stay with the patient until discharge, allowing for easy sterilization and sanitization. This will allow mothers to pump as needed, even in isolation. For our mothers with serious illnesses who will require ICU care, we have breast pumps that can go to the ICU with the patient and stay with her for the duration of admission to the ICU. Our ICU nurses are familiar with the breast pumps, and we have experience with helping mothers in critical care situations establish and maintain breastfeeding. One unknown is handling of expressed breast milk and whether that would be how and whether that would be transported to the baby to use in the case of acute illness. One other area of concern I have going forward is finding the balance between early discharge to get the dyads home to minimize hospital exposures and keeping them long enough to ensure a successful start to feeding for baby and ensuring mom is without complication prior to discharge. And this is an area of work in progress.
Great. Thank you so much for that review. That was very, very helpful. It gave us a very good glimpse of what's happening. And I was going to ask about the cleaning of the bottles of breast milk before they go over to the baby. And obviously you said that that's something that you're working out at this point.
We do not have an official plan for that. My suggestion, I was thinking about this earlier today, I think that my suggestion would be have mom express the milk, put a lid on the container, and then have someone, a gloved person, wipe the outsides of the containers, drop them into one of those clean Ziploc bags, and then leave the room with that and then transfer it cleanly somehow. I can't think of any other way to ensure that the outside of the containers would not be contaminated potentially in mom's room. If anyone else, any other suggestions, I would love to hear it.
Yeah, yeah. I think the other point that you brought up is interesting too, about the early discharge. And I've had a couple patients in the last week who delivered and left within 24 hours just because they wanted to get out of the hospital setting. And then it's almost like playing hot potato with these families, because we have to figure out how are they, the safety net is now changing so suddenly for many of us in the United States who are used to having our patients stay for the first 48 hours. But that segues into our next presenter. Karen, I don't know if you want to.
Oh yeah, so Joss Anderson works at Monarch in Ottawa, Ontario, Canada, maternal and newborn care clinic, which receives hospital discharges for smooth transitions back to their primary care provider. She also provides breastfeeding medicine and newborn care at the hospital and teaches medical students and residents.
Hi, everybody.
Hi.
All right, so mine kind of ties everything together. So I'm in Ottawa, the capital of Canada, if nobody knows. We have actually just today confirmed community spread, but it was suspected last week. We have estimated about 4,000 cases, about 20 positive here. Our city has been doing stay at home, and we've ramped down all non-essential visits, so closing ORs, etc. So in the hospital, so I do newborn care because we directly link with our discharges to our Monarch clinic. And our hospital works on a 24 to kind of 48-hour discharge, so ready-based discharge. The protocol for actually what we're doing is still hoping to be confirmed in the next little bit, very similar to Chandri's. If it's COVID positive, then the baby, if the mom is still well, they're actually keeping the baby in the room. They're having a drape though, so mom can have the baby to breastfeed, but otherwise there's another support person in the room that will be doing all baby care otherwise. If the mom's not well, then the baby is being taken to the special care nursery, the NICU. If they're a person kind of under investigation, they get discharged home, they're actually getting a call from the nurse within 24 hours. And the problem here is we actually don't know what the plan is if they are positive and where their follow-up care is going. So currently, a large number of the patients get discharged to our Monarch clinic. And the way our clinic works is that we see the babies for average about 2 or 3 visits, and then they get discharged back into their primary care provider. So that's either a pediatrician or a family physician. So right now what we're doing is we're screening all of our patients on the phone the night before, and then as soon as they come in as well. And if they screen positive for symptoms, so not just like right now we're only doing testing swabs if they've had recent travel or a contact with a positive case or suspected case, or travel with respiratory illness, or healthcare workers are being tested. So if they screen, the positive screen for Monarch means any symptoms, so travel doesn't matter. Then what happens is they actually get a telephone call from me, and I screen them and figure out where we're gonna go. And this is where we're struggling because we don't have this in place yet. But currently what is happening is if the mom is unwell but baby is okay, then we're bringing them into the clinic at the end of the day with a well support person for a quick wait and Billy check, because we have a transcutaneous Billy machine that we can use as well. So that's where we're at now. If they don't have anybody, we're not sure. The current plan is actually to send them back to the hospital to have an assessment there. So that's our current strategy. As of, I think it was yesterday, there's no visitors allowed in the hospital anymore, and every patient has to come through the main entrance. And what they're doing is they're calling up to triage, and a nurse in PPE comes down and will bring the patient up and then page the pediatrician on call. So I'd also page the pediatrician, or if it's an unwell mom, we also can send them back too. So I'd be paging the OB as well. So there's a bit of unclear, we're not sure what's going on exactly with that. We're also struggling a little bit as to either our numbers are going to go up because a lot of patients that you heard in the first hour want to stay with us and don't want to go back to their family physicians or pediatricians because of the risk of infection with other patients there. So we might be keeping them a bit longer, or we might be trying to move them out quicker and having actual specific triage, or not triage, but other care clinics to see these patients specifically with some of our larger family medicine clinics in town. Sorry, I just wrote down a few things here that I'm making sure I'm not forgetting. With the, so currently for telemedicine, I'm just doing telephone call. In Ontario, we're allowed to use whatever platform we want. I can FaceTime the patients if I want, we're covered by it. And they also released billing codes, so we can bill for it as well. In regards to public health, because we heard Shauna in the first hour talking about that, our public health is very strained at the moment. They've pulled all our nurses into the telephone lines and assessment centers to be doing that. So they've actually shut down all of our breastfeeding drop-in clinics, as well as the home visits. So if they screened high risk in the hospital or in our community clinics, they could have a home visit, but it's all been shut down. So Monarch is kind of a central area for where we're going to be screening and helping out with this big lack in care at the moment. A lot of the family physicians have moved to telemedicine now. And what they are, some of them are doing are having kind of a clean clinic in the morning and then a sick clinic in the afternoon. So we're hoping also they might be able to bring some of those babies in for well checks. All vaccines have actually been held at the moment while we're figuring out our plan. And then in regards to, I also do breastfeeding medicine. So looking at our breastfeeding consults, I'm probably going to be doing those from home. And then if I need to, I have my team members at the clinic during the day too, that if I needed them to go in and do a quick weight check or to check for mastitis or something like that, that they can be seen as well. And then I had asked a few questions in the first hour was about scales. So one of my thoughts was getting the public health scales and using those. And the other is renting from them somewhere else as well. And then having two, so people that can afford to rent, they could rent a home scale. And for those that truly can't, we would have some of the public health scales perhaps to use. There's a lot up in the air. So that's kind of where we're at now. I think I hit a lot of things, but I'm open to questions, obviously. Thank you.
Great. That's a very good summary. It sounds like you're still in the progress of, working things out, which we all are. One question I have for you, I saw something posted about telemedicine visits for primary care physicians in Canada that's going to cause a huge hit income-wise for, I don't know if this is province, if this is related to, if it's associated with certain provinces.
So it's province dependent based on how we're paid. In Ontario, it's definitely huge. Like our numbers have gone down a lot. So there's different billing codes, but they're less for sure. And I know Alberta, where Shauna's from, she could talk to it a bit more if she's still online. They've been in a really big battle politically and having a lot of healthcare cuts recently. And then I know the government has been making other changes. So with telemedicine, bringing in kind of what sounds like she'll know better, I'm not 100% sure, but a large corporation to do the calls for family medicine, which would basically take away the business from what I understand from the current family physician offices. So we're trying to encourage all the patients there to still see their family physicians.
Mm-hmm. Mm-hmm. Interesting.
Did you want me to address that at all?
Sure.
Sure. So unfortunately in Alberta, we have been battling our government to try and protect primary care. Unfortunately, they have kept our phone, video, or email code only paid at $20. So currently we can't bill like a normal visit. They at least removed the cap on the number of phone calls or video calls you could make per week, but we cannot sustain ourselves with this billing code. We're hoping for an update tomorrow. So this has been a major problem. We can't keep our staff, we can't keep our offices with this payment. And so we have a lot of pressure on the government to change this for us. They've brought in this program called TELUS Babylon, which is essentially a virtual walk-in clinic to try and provide care. And unfortunately, they are getting paid more than we are to do telemedicine, and they have no access to patient charts. They have no responsibility I hear that lots of times they just tell people to go to the emergency room, which is really, really inappropriate in this current state of affairs. So we are.
Yeah, thanks for sharing that. If you have some information that you can just like maybe post like in the chat, like any kind of website or Facebook chat discussion about that, that would be great. I think we're going to just kind of stay with the inpatient issues. Okay, so I want to introduce Dr. Lily Simon. She is a pediatric critical care physician and a board-certified lactation consultant at the university, and a clinical assistant professor at the University of Maryland School of Medicine in Baltimore. And so Dr. Simon has another perspective on just readiness in the intensive care unit. Hey, Lily.
All right. Well, hi. So thank you for having me. I think I bring a different set of, I think, eyes to the COVID. I think we're definitely, so I'm a pediatric intensivist, and I do some breastfeeding medicine with our patients in the PICU. We are working, of course, to, prepare to receive all the critically ill kids that will probably come. And we are changing some of the flow in the hospital, and I can talk about what we're doing so far. We have had some patients under investigation in the PICU, but they all turned out to be negative so far. So we didn't have a positive patient yet. So some of the things that we are changing in terms of our routine from, what you're doing in the hospital, I think starts from, we are a big, we have a transport team, and we receive patients from all over Maryland. So one of the things sometimes we use to accept these patients directly to the PICU or to the ED, or occasionally to the floors. And so those patients are, every patient coming in to the hospital now with respiratory symptoms, with suspicion, they need to have a respiratory viral panel done. So if we identify another virus, then, for instance, the patient has RSV or HMPV or something else, then we admit this patient and just treat them as usual, or just to the level of care that they require. If the respiratory viral panel is negative, then we talk to ID, and if the ID physicians think that this could be COVID, then we send the COVID and we admit these patients to one of the areas. So I started saying about transport. We're doing this on transport, saying that we're not, first of all, for transport, we're not accepting patients directly to any place unless we know that they have another virus that's not COVID. And if not, we send this patient to the emergency room, and then they have to be tested before they come. They are admitted. For the admissions from the emergency room, that's what we're doing. I mean, we try to identify another source, and if we don't identify a source, then we talk to ID, and then we have a joint decision if we are going to send COVID or not going to send COVID testing. If we do send COVID, then this is a patient under investigation, and they go to a negative pressure room and stay there with protective equipment until we have the results. That's usually we're able now to get the results. It takes about 48 hours for us to get the results. Some other changes that have happened is we have a limited number of negative pressure rooms in the hospital in general. So for instance, in the PICU, we have a 19-bed PICU, and we have only two negative pressure rooms. So of course, we're leaving those open as much as we can to, for patients under investigation. And as soon as the COVID test comes back negative, we've moved those patients out to open up the room. We anticipate that this is not going to be enough, and this is going to be challenging. So we are thinking that maybe we are gonna divide our unit in two, and one half of the unit then we can create sort of a different flow, and that will be a COVID sort of unit, and the other unit will take care of the other patients. All of the elective surgeries have been canceled in the hospital as well. I think this happened in Maryland and at Hopkins as well. They all canceled all elective surgeries. The other thing that has changed in the hospital is that now they used to have a hospitalist service, and the hospitalists were not in-house 24/7. The University of Maryland recently opened an IMC service, and there was always an IMC provider, or not always, sometimes an IMC provider in-house. So the hospital also changed what they're doing, and now there's always, the plan is starting Monday, there's always going to be a hospitalist in-house for the floor as well. The other thing that has been done to try to save some protective equipment is that the residents are not seeing the COVID patients or the patients under investigation, to try to save some protective equipment. So those are seen by attending only, or if they are in the PICU, they're seen by the attending and the fellow only, to try to save some resources there as well, and also to try to not expose the residents so much. Of course, we have a lot of, backup. Nobody can travel, take vacation. Everybody needs to be available, because if anybody needs to go in quarantine, of course, the PICU still needs to be staffed, and we have to be available to just chip in whenever we're needed.
Yeah.
Yeah.
There's one question for you, and that is about the co-infection rate.
Yeah.
Yeah.
I don't have an answer for that, and we know that, and we have discussed that's a problem. There is a co-infection rate, right? And the fact that the patient has RSV or HMPV doesn't mean that they don't have COVID. We don't have a solution. And the one concern is that they're very concerned that we're not going to have enough, not only testing for COVID, but even for RSV. That there's a limited amount of the reagent that you have to send, both the COVID and the RSV, and we may, the COVID and the respiratory viral panel, and we may actually not have enough. And I'm sure that's a problem. It's going to be a problem country-wise, not just in Maryland, that we may just run out of the reagent to even send not even talking about the test itself, right? I mean, even to get to the testing site.
Yeah, Liliana, where we are, they took all of the little vials that you put the swabs into. They all have that liquid cultural medium, and under sterile conditions, they split them all into two, so they have half as much to try to stretch them.
Yeah, it has been an issue as well. So these are the things that are sort of happening, in the hospital in general, not related to breastfeeding. There are several. I mean, we can anticipate a lot of challenges regarding breastfeeding in the inpatient setting.
No, but that does give us an idea, especially for people who aren't connected to a hospital, of how we're trying to prepare. Now we're going to go.
Can I just say one thing? I think the other thing that I'll stop shortly. But I think the other thing that has been very interesting and very good in the inpatient setting is that there has been also a lot of collaboration between adults and peds. So, one of the things that they're looking at is, for instance, the adult side they have more negative pressure rooms. So we may actually have a part of we have another sort of PICU in the adult floor. Of course, we'll need another attending, and we'll need to send another, PICU nurses. But there has been a lot of collaboration. We also have been receiving a lot of information from the PICU people or the ICU and PICU people from Seattle. They are a few weeks ahead of us in this infection, and trying to prepare for all of this.
Yeah, I agree with you. We're having the opposite. They're actually looking. We have 4 negative pressure rooms that are on our postpartum floor, and they're telling us to anticipate that we're going to end up with sick adult patients in those rooms.
Oh.
So we're going to talk to Nan Dahlquist now, who's a pediatrician specializing in newborn care and breastfeeding medicine with a private pediatric clinic in Hillsboro, Oregon.
Hi. So I think think Chandria really summarized what's happening in hospitals and obstetrics really well. I know I work out of a private clinic. I round on babies at a major medical center that delivers probably half of all the newborns in the state of Oregon. And then I also work out of a small community hospital that's affiliated with our university. And so both of these have developed your standard policies for moms who are positive for COVID, with the primary plan to transfer babies out as soon as baby's born to isolation. And I know that we are really, they're talking that probably within a week, or we might be out of PPE for the hospitals and for sick patients. So we're becoming somewhat critical, that the availability is becoming rather critical. The testing has just really been able to increase. We now have local testing, which all the tests were going outside of the state. So in Oregon, we're 3 weeks in from our first target case of COVID in the state of Oregon. I am kind of in that epicenter. 43 of those patients are out of my county, which is the highest number of any. And there's been 114 confirmed cases and 4 deaths. Those 4 deaths all in that target area, target population of the elderly infirmed. So currently there's policies in place. I am still going in and rounding on my newborns. So far we have seen no evidence of, again, it's just no evidence of COVID in our labor and delivery areas, but that's relative, as we've discussed at length before. So I'm still going in and rounding on my newborns. I'm staying, I'm doing I've always done, take the stairs, sanitize my hands the minute I get on the floor, sanitize my hands the minute I get in the room, wash my hands immediately afterwards. So I am not using masks when I go in and see these families. Again, because I am 100% isolated from sick care in my clinic. I only see newborns and I only see well newborns. And the facility, in the area of my clinic, it's only for well care. And we're being very, very complete in making sure that happens. So I am just washing and doing good hand washing before, after, and then after using all of the computers outside. I don't access any computers within the room, only outside of the room, and then sanitize the minute I get in my car. So I'm doing everything I can to keep that all separate. So I'm going to 2 different hospitals. I've determined that probably, unless we have some kind of for well newborns, I am not rounding on them on a daily basis. I'm checking in with the nurses. I'm doing telephone evaluations. I'm talking to parents, but I'm not going in. And for our normal vaginal deliveries, multi moms, no complications, they are going home at 24 hours. Our primips rarely are normal and uncomplicated, and so they're usually going home at 48 hours. Our C-sections are pretty much 48 to 72 hours. And the problem is in that major hospital setting, any mom who has a history of preeclampsia, elevated blood pressure during her delivery time actually is having to stay for 72 hours. So I'm not sure if there will be some modification for women who are slightly lower risk with hypertension versus higher risk with hypertension. So far we haven't had any babies separated. I have worked with the perinatal group to try to make sure that they're familiar with the ABM protocol on trying to keep families together as best as possible, because this major hospital system has become rather lax at making sure that moms are pumping and are able to establish a vigorous milk supply. So we're really working to try to keep that going, and to keep that. The smaller hospital, the policy at place, because it is such a small hospital and they don't have available rooms to be separating everybody out. They're in the process of building an NICU and a peds floor, but they're not complete yet. And so in that hospital, the plan is to set up a plan with all pertinent providers to have a say in what's best to do with that family. The most likely case, if they're that sick, they're going to be transferred to the university hospital and managed there, which is a much more robust system.
One question I have is, so just going through the basics again for some people who are starting to develop policies at their clinics. if a mother comes in, and maybe Chandra can help this too, is if a mother comes in and she's in labor and she has some mild cold symptoms, and testing, depending on where you're at, where she delivers, is going to vary in terms of test results and whether or not they're testing. Some people have said that those mothers are being separated automatically from their babies postpartum until it's proven that they don't have COVID. And so I think that there's a lot of different interpretations of the CDC recommendations. And I'm wondering what's happening, what your recommendations are for people who are dealing with that.
We
Personally,
don't have
I
the
think,
resources.
yeah.
Maybe Chandria, why don't you?
Sorry, we don't have the resources to separate every single dyad with a sniffle. But we will probably going forward recommend at a minimum that they use the 6-foot separation in the room and hand washing until something can be determined, because there just isn't that many rooms available for people. Like, there's just no way that we can separate those moms and babies.
Right.
And that's exactly at our facilities, even our larger facilities. They're talking about moving them over to the pediatric floor, which is going to be a different floor than the sick mom. And I just don't think that is the best use of resources, especially when things are getting a little critical, that keeping those babies and those moms, we have big enough rooms. We don't have little tiny specialty care unit rooms that would preclude 6-foot separations between moms and babies. And so I'm highly advocating for that. And I made sure that the policymakers at our hospital knew about the ABM policy, that they'll incorporate that, because most of them are taking that ACOG approach that Anne, you referenced to a little while ago, or a few days ago, that the first step is to separate them. But I just don't think that's practical.
Hey, this is Karen. I just want to throw out a third approach, because it may come into play for some people, and they're talking about it where I am, which is we have a giant, 50-bed floor, and we have a nursery that we use and a second nursery that we keep empty most of the time. And they're talking about doing some cohorting of babies in the second nursery if the moms are not sick, but they're PUIs, keeping those babies in there more than 6 feet from each other. I think there's some amount of insanity that is going on.
I think that's ridiculous.
But I think, there are a lot of issues from keeping the milk, if there's pumped milk, how is that going to be kept clean, to, who are these supposed healthy caregivers that are going to be taking care of babies if they're separated? Part of the reason the cohort plan has come up is because they have this thought that, one nurse could take care of multiple babies. If we don't have the staffing, they're potentially going to take a lot of our postpartum staff to work in other places in the hospital, which is, I think, another reason that it'll be better in the end if moms particularly are not ill to have their babies with them. I think if they're coughing all over their baby, that is not good.
Right.
There's some real inconsistency to that approach, because again, you've got a nurse who's working with a variety of newborns, and it's going to be really hard to have enough PPE to change out every time she goes to a new baby.
Mm-hmm.
Yeah. Rima brought up an issue in the chat about the AAP section of neonatal and perinatal medicine taking a stronger stance on separating the COVID positive and the COVID positive, and ill mothers basically, who are under investigation from their babies. But as you say, both of you, that may be a recommendation, but it's going to be impossible to do that because of the space. But this is something where, for anyone who does have any influence on these policies, I think that I'm personally very fearful about the separation. I think we all are. I think we all understand that mothers may have a very difficult time establishing breastfeeding, and we're putting these babies at risk, I feel, if we cannot make sure that they're breastfeeding, and then making sure that the staff has the ability to teach hand expression, and then transferring that colostrum that's expressed early. Pumping is one thing, but pumping isn't going to work in the first 24 hours. So they're going to have to hand express and know how to do it well, and have a way of transferring that colostrum to the infant. And then, of course, if the infant's separated, there's that risk of the infant getting sick from someone else.
Yeah, I think that's what would scare me the most if I was a new mom. Like, you're going to put my baby where and who is going to be with them?
Right, exactly. Yeah, because that person could be asymptomatically shedding anyway. I mean, we have to assume that it's like influenza. At a certain point, everyone's probably carrying it or spreading it or in early stages or whatever. And so
Can I throw?
Yeah.
Oh, go ahead.
I guess I wanted to, I know that we're going to talk about neonatology, and maybe this question segues into the, talking to Dr. Myers, who's our last panelist, about really the risk to these infants of COVID. And we've heard so much about elderly people dying. And one of my office partners looked at, like, he crunched the numbers for the people who died in Italy so far, and the vast majority of them are like over 80. And I know people are hospitalized quite a bit, but the actual deaths are much higher among the elderly and the immunocompromised. And so then, you know, what is the risk for a baby who's breastfeeding? Lily, do you have any idea? Or we can bring on Dr. Myers as well, and unless you want to talk first, Karen, and ask something else.
Well, I'll just briefly touch on that and say there was a case report out of Singapore of a 6-month-old who was hospitalized only because both of the parents were ill and needed hospitalization. And there was, you know, the baby became an experiment because they thought they were probably exposed and there wasn't anyone else to take care of that baby. Baby had high viral loads, but was very well, had a brief self-resolving temperature of like 100.5 for less than an hour. And so I think there's a lot of good news in the data that we're seeing out of Seattle. They had 4,000 tests of children who were suspected and only about 3 were positive. So I find that to be very reassuring. But I think it is important for us to keep in mind that we still are at risk as providers and trying to make smart decisions so that we can stick around and keep taking care of all these patients. I had 2 related ideas for sort of more of the public health approach to dealing with hospital. One was, there are some people who've been posting about making prenatal breastfeeding education available free online and trying to help our systems encourage people to get that education where they might not have gone before if there was a charge for a live class, to help them be more prepared when they get to the hospital. And secondly, trying to work with our systems to convert some of these new mom support groups to Zoom meetings. I mean, after using it today, I'm like, wow, this is really easy to run. That might be a source of support for some of those people who, you know, both emotionally and just keeping them from making complete wrong turns with their formula supplementation may be really important.
Yeah, I actually thought it's so funny. I guess we think alike sometimes. I was thinking yesterday that
is great to hear. I'm so happy.
My to-do list is to maybe put together, like, have a number of physicians who are on today or anyone put together like a quick recorded slideshow, you know, on prenatal care, on prenatal breastfeeding education, and then have it be for any, you know, have it be for free. We can put it on our website, and then have anyone, any families watch this, because I think that's one of the big issues that I'm seeing on Facebook and among other groups, is that people don't know where to go for prenatal education because the groups are closed. So if anyone's interested in putting together a prenatal class, let me know. I think we could do that really easily through our organization and get that up there.
Hi, it's Joss. We actually do this at Monarch. We've been doing a prenatal through, I believe it's through Zoom actually, for a little bit now. We started it back in the fall.
Great. Yeah, I think having something pre-recorded that they could just watch, you know, whenever they can.
Yeah, that'd be great.
Yeah. Okay, so our last panelist today is Dr. Eliza Myers. She's a neonatologist and breastfeeding medicine specialist and is an assistant professor of pediatrics at Yale School of Medicine and the medical director of the neonatal intensive care unit at the Yale New Haven Children's Hospital at the Bridgeport campus. This campus is an 18-bed level 3 NICU that supports the much larger, greater than 60-bed level 4 academic NICU in New Haven. Hi, Liza.
Hi, can you hear me?
Join us. Yes, sounds good.
Thanks so much for having me. And I wanted to, Chandria's summary was so thorough and really mirrors a lot of what is happening in the greater Yale system. And then I was listening with interest to the discussions about separating and non-separating. And in the absence of better information, the Yale system is taking a lot of guidance from what's on the CDC guidelines, which describe that the baby should be considered a person under investigation until proven otherwise. But from a practical perspective, our testing has gotten pretty fast. So we can get a test result in a little over 8 hours. In the New Haven campus, they can get their test results back in 6 hours, and because we have to courier ours up and back again, or I guess we only have to courier it one way, we're more like 8+ hours. And so in the last couple of days, we have separated a couple of mother-baby dyads. I'm thinking of one baby one well-baby nursery mother-baby dyad, and then a baby that was a NICU patient in whom the father developed a febrile illness. And we made the baby, we tested the baby while the father was being tested. So that, from a practical perspective, has been very helpful because there hasn't been a lot of personal protective equipment used. It's not days of separation, for example. And then thinking about somehow the issue of what do we do with mom's milk while she's pumping it and getting ready to, if mom is COVID positive or COVID potential and is pumping milk, nobody's made a big deal about how the milk will be handled. I was just thinking about, I think Chandria's suggestion is exactly right. I think the milk a cap goes on and it gets wiped down. There was an article that the New York Times summarized the other day about the behavior of the COVID droplets. And luckily it seems like a droplet that's pretty well behaved. It's easy to kill on surfaces and it's not particularly aerosolizable. So I think that's good for us. In terms of babies, I have not done a thorough literature search, but my understanding is that they don't really get sick, which is great for us. And so a lot of our worry and planning and concern isn't so much about the medical management of our patients, it's the conserving our staff. So we've taken the same scary restrictions for visitors. In the NICU, there can be one visitor at a time per baby, and it has to be one of the two banded parents with no, the other parent can't even wait in the hospital, unfortunately, because they don't want visitors wandering around. The rest of the hospital has no visitors. And those are really measures to protect the staff, obviously, not the patients, if that makes sense.
Yeah. Any questions about NICU care? We've heard from some of the neonatologists that they have not felt that so far things have really changed much. And, you're always dealing with a very vulnerable population. And, before the COVID thing, you were probably careful about during flu season, if parents were ill, to have kind of similar recommendations?
Yes, I agree. My personal workload does not feel different. It's just the mood of the hospital feels different. And there are some other changes that are noticeable. A lot of the Purell dispensers have been taken off the wall and replaced with a sign that says Purell's being conserved. Please go find a sink and wash your hands. And gloves are no longer kept in patients' rooms because the boxes of gloves were disappearing. So there's stuff like that sort of is a constant reminder, but our actual workload and our actual workflow isn't much different. I guess we used to have family-centered rounds and invite families to sit with us in our workroom, and our workroom isn't quite big enough for that. So we've actually separated our we all sit in our own corner of the workroom, which looks and feels a little bit weird, and to get as far away from one another as possible. And we don't allow the parents in anymore. And parents understand that. So they either get a phone call after rounds or a personal visit where we stand 6 feet away and tell them the day's update.
Mm-hmm. This is Lily. Can I just make a few comments here? Sure. And a question for Eliza. So a comment is, we had in the PICU, we have been using Zoom with the parents who are not able to be in the hospital for now, I think 2 years, and it's working really, I mean, it's worked really well. So that's an option to Zoom in the parents doing, so you can still do, patient-centered care with the parents in rounds. And I have a question for Eliza. Sure. Has it been an issue of getting this milk into the hospital, once the moms are discharged? One of the concerns is that now there's decrease in public transportation as well, and decrease in access to the hospital in general. Are you able to actually receive the milk to the hospital for your NICU babies who are, who still need the milk, and the moms are not in the hospital anymore?
It hasn't come up specifically, but I can imagine a circumstance where it will. We're very fortunate to have the Friends of the NICU has a fund for helping patients with things like Uber cards to get around. Although I don't know, can you still take an Uber anymore? You make a great point. I don't even know if they have Uber anymore. So I don't know. That may become something that I have to think through.
Because we were starting to brainstorm on how to even get the milk. If you get somebody to bring it to the hospital, and are we going to give it to security and somehow get it to the PICU? Are we, somebody's going to go down, but of course you can't have a staff go down all the time to get the milk. And we're starting to brainstorm.
Yeah,
anticipate that this may be an issue.
The banded person could bring it up, or perhaps it would be delivered to security and brought up. It should already be labeled because people have taken the labels home, but you're right. What if they haven't been in the hospital? These are great questions.
Mm-hmm. Yeah. There's also, I think that's one area that at our level 4 NICU, the lactation consultants have had questions about just the handling and how milk is actually getting to the hospital, and how it's going from a mother who may be hospitalized at the UW and then a baby in the NICU. Like, what's a safe way of transferring that milk? I wanted to just point out too that Havana did put out their statement. There may be some questions about donor milk as well. I don't know, Eliza, if you've had some questions from. I assume you use donor milk in your NICU.
We do, yes. And the milk bank that we buy our milk from has said that they're going to prioritize the NICU patients, that they're not going to be using milk or I don't know if they specifically said they're not going to give it anymore to or sell it anymore to well baby nurseries, but they want to make sure that their NICU populations have, that they're prioritizing the NICU populations. But I've been framing this in both the NICU and the well baby nursery as like, this is a moment to really to ramp up our efforts to help mothers provide and produce their own milk, because this could be incredibly important or devastating to the NICU population to lose this source of human milk.
Right, and I think that's an interesting point, because I think that in talking to another neonatologist, there's a critical need to train NICU nurses in the field of just, basic breastfeeding anatomy and physiology, that's not something that is like for baby-friendly hospital nurses. If a hospital is baby-friendly, there is an educational, there's education, there's training, there's 18 hours of training. But for NICU nurses, they haven't really been part of that. And so there are some NICUs around where, sometimes mothers may not be, encouraged to pump for the first 12 to 24 hours until the baby's settled in or whatever. So we do need to really encourage mother's own milk. And mother's own milk is superior to donor milk for sure. So, yeah. I think Lori Winter, would you like to talk about the recommendations for PPE guidance for your hospital? Let me see if
Hi,
she's...
everyone. So my organization, we're close to Philly, and New Jersey is one of the 5 states that has like an absolute lockdown. So we've converted everything to telephone, telemedicine, and for those healthcare workers that are in the hospital, I think the most critical issue that's facing everyone now is how to conserve the PPE that we have available. And so the organization created guidance for when to don a mask. And a lot of people were trying to reuse, but every time they reuse, they would touch the mask, which virtually renders the mask useless. So really, if you're in a situation where you're seeing patients rapidly, such as an ICU setting or at the ED, the recommendation is to just keep it on continuously, not to touch your face, and just keep the mask on continuously so that it doesn't have to be reused or discarded after touching. And so, so this grid just helps provide some additional guidance for when PPE needs to be used, which really is for the patient that's under investigation that is symptomatic, and which masks need to be worn, in that case, the N95 respirators, eye shields, gown, and gloves. So I thought this was helpful for those that are in that setting, providing care.
Thanks. I want to mention that I've heard a couple interesting things about PPE. One is that my aunt and uncle are living in Phoenix right now, and there's a distillery right down the street, and people can come anytime and get their own hand sanitizer that the distillery is making from their own alcohol. And you can bring your own bottle, and it's like BYOB to the distillery, and then they fill it up with, rather than booze, they fill it up with hand sanitizer.
Yeah, a lot of the beer manufacturers in this area have actually converted their production from beer. Yeah. So they're repurposing.
Right. It's great. I mean, you know, while people can't sit on a bar, might as well get hand sanitizer. And then our engineering students are 3D printing the face shields. And our pharmacy school is making hand sanitizer as well. And then I talked to a friend who is a clinic coordinator or medical director, or not medical director, but administrative director for FQHC in Milwaukee, and they struggle financially. They mostly serve people who are mentally ill, and they are reaching out to some volunteer groups to sew some masks and cloth. It's something that the CDC mentioned as a last resort, and right now they're feeling that they are at the last resort. Although there looks like there's also some research showing that cloth masks are not very helpful.
And so one other thing in our community, one of the local is looking at taking some of the defined, sterile fabrics that are in the hospital. Not really fabrics, they're paper, and seeing if constructing face masks, sewing face masks out of the protective fabrics that are available, if that would be an option instead of trying to do the cloth.
Right. I was thinking about that too. That makes total sense, because if you're using this, because it's also going to be droplet protective, and it's breathable, has a lot of qualities, that would make sense.
And it can be sterilized after it's been created.
Mm-hmm. Right. Yeah. Any other comments? I think we're closing in on.
Hi, it's Jocelyn. Can I talk just about the PPE?
Sure.
Just some other ideas. So I actually put out a social media call and got inundated with people offering. What we actually did is we've used our medical students because they're not really doing anything. And I have a group of them that are organizing to call dentist offices, like anything you could think of. One of the really big things that I was able to do was I linked with an old friend who works at research labs, and she tweeted out and started a whole file for all research labs to donate stuff. So we've been able to pick up a whole bunch of N95s, surgical masks. They're going to be making some sanitizer. We also did the distilleries in the area as well. Restoration people have some as well. So there's a whole bunch of ideas. So if you put that out, and I'm not sure what your medical students are doing, but they've really mobilized to help out. They've also put lists together to provide healthcare or healthcare providers with babysitting, going grocery shopping, errands and stuff like that as well.
Great. Yeah, that's a really great idea. And I see some other people have had other ideas like nail salons, vet clinics, etc. We have just a few more minutes, and we do have Dr. Monica from Brazil. And I wonder if Monica would like to talk about what's, Carceles, who I wonder if you'd like to talk about what's going on in Brazil.
Hello, Anne.
Hi.
How are you? In Brazil, we are doing many different things. We try to follow protocols, but in hospitals, some hospitals are using masks to attend symptomatic patients, and others are not. And because patients are very afraid, because many nurses and doctors attend the patients and they are afraid to have the virus. The nurses have the virus. So we try to follow protocols, not use the masks or gloves or gowns, but it's very difficult to follow this because the patients are very afraid. And we didn't have in our hospital or any hospital that I know, any patients, any pregnant women with COVID-19 yet, but they will appear very soon, I think. I'm very happy to be with you here so I can see that everybody has difficulties. So it's very, very good to be here. Thank you.
Yeah, thank you for joining us. Yeah, and then we have Yvonne before. Yvonne, I don't know if you can join in to talk about what's going on in New Zealand. I don't know if she's still on or not. She was on earlier.
And she did post, this is Nan Dahlquist. She did post on Facebook, Yvonne did, that they're actually moving her clinic away from the medical center. And so I think that's what she's probably doing right now, is they're going to move her clinic into a secondary site that gets them away from the main medical center and try to be a little more secluded.
I see. Okay. And I don't know that we have anyone from Australia. I think Marnie Rowan was going to join us, but I don't think she ended up joining us. So, okay. Well, thank you to everyone. It's I think it's exactly 4 o'clock Central, and this was just so informative. And I feel like many of us are experiencing very similar things, and so I think and I've learned quite a bit from others as well. And so if you would like to have 2 SERPs, we'll be providing 1 ELF SERP and 1 eSERP for this conversation. I did put the link to that evaluation in the chat, and let me see if I still have it in my, yep. And I'm gonna just put that in again, so you can use that link. So thank you so much again. And then this recording will be available in about a day or 2 after we compress it and alter it. It'll be in our podcast series. And feel free to share it. And then we will try to have we'll have enduring education SERPs so that anyone who watches it could get 2 free SERPs. Thanks.
Thanks, Anne. Great job organizing.
Thank you.
Very timely. Thank you.
Thanks, Anne. That was fantastic. Take care, everyone. Stay safe.
For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.